will start this session. In this session, we have got our chairperson as Dr. T.V. Shekhar. He is a professor and head of the Department of Population Policies and Program. His research areas are in social demography, aging, RCH, and history of population. We have our discussant, Dr. A.G. Khan. He is a professor and head of the Department of Sociology at Alad Gulbarga Institute, Karnataka. His research areas are in field of RCH and family planning. We have Sunil Sarode, who is a rapporteur for this session, and he's assistant professor in Department of Migration and Urban Studies. His areas of research are in HIV/AIDS, and basically he's looking at Nepali migrants. Sir, over to you, Dr. T.V. Shekhar, for conducting this session and providing the timing for each of these sessions, sir, for each of the participants. Thank you, sir.
Thank you, Dr. Manoj, and good afternoon and welcome to this technical session on aging, health, and living arrangements. And we have 6 papers to be presented in this session. And after that, we also have a discussion, Dr. A.G. Khan, a sociologist, demographer, and an alumni of IIPS. And so I'm sure all the 6 paper presenters are there now. So in order to have we need to have a strict time management now. So I would request each presenter to take maximum 10 minutes. And after all the 6 presentations and over, the discussant will give his comments and remarks. Then we will have some time for question answer session. And we have our rapporteur, Dr. Sunil Sarode, who is, and Ms. Shalini Sen with us. So let me invite the first paper presenter, Junki Kundu, on her paper is on what predicts elderly seeking healthcare utilization across public and private institutions in India, evidence from NSSO. Junki, you can take 10 minutes, start your PPT now. Yeah.
Yes, sir. Good afternoon to all my respected sir, ma'am, and my other friends. So, sir, now can I start my presentation?
Yes, please, please.
Okay, good afternoon to all. Here now I'm going to present the topic which called what predicts to elderly in seeking healthcare utilization across the public and private institutions in India, evidence from NSSO. So as we know, the elderly population in India is expanding fast, which indicates a growing share of the elderly people with a more specialized needs for health and support. And between 2015 to 30, the number of the elderly population ages 60 years or over is expected to grow by 56% from 901 million to 1.4 billion. So as we know, as people growing elderly, they are more likely to need healthcare due to the declining functional capacity and increase the complex health problem. So a study conducted in 2010 for the oldest old group, the private hospitalization is close to 2/3 of the total healthcare services. So it is also important to note that in India's health delivery system varies according to region also. The distribution of the private health sector facilities between the states and territories in India is even more unequal than those in the public sectors. So now I come to discuss my objective of my paper. The study is attempt to investigate the predictors or the factors of the choice of the inpatient healthcare services of the Indian elderly between the private and public services under the Anderson's health behavior model. So basically, this Anderson's health behavior model assumes that the choice of healthcare utilization, public versus private, is a type of individual behavior. In effect, several socio-economic, demographic, and health-related factors influence individual to choose over public versus private hospitalization. This Anderson's health behavior model categorized under the 3 broad categories like predisposing factors, the enabling factors, and the need factors. So what is the predisposing factors? Basically, some individuals have a propensity to use health services more than the other individuals, where a tendency towards use can be predicted by individual characteristics, which exist before the onset of the specific episodes of illness. People with certain characteristics are more likely to use health services even though the traits are not directly responsible for the health service use. These predisposing factors are basically include the demographic, the socio-structural factors, and the attitudinal belief variable. Now, what is the enabling factors? Basically, the enabling factors means that a condition that permits a family to use regarding the health service. Enabling conditions make up people to use the health services. Like this enabling condition generally include the family resources, like the monthly per capita expenditures of the family, the level of the health insurance coverage, the community health facilities, and the price of healthcare services, and the region and the place of the residence, like rural versus urban. And need factors, need for the care basically define the most immediate cause of health service use. The need factors including the disease profile of a people, like communicable versus non-communicable disease, the requirement for the surgery. So this is a conceptual framework based on the Anderson's health behavior model. Here are the predisposing factors, enabling factors, and need factors which determine of individual to choose the healthcare services, public versus private. Basically, these predisposing factors include the age, the marital status, the gender, caste, religion, education, and the family size. And the enabling factors include the monthly per capita expenditures, the health insurance scheme, the source of the finance, the place of residence, the region, and the economic status. And the need factors include the disease profile, the need for the surgery, and the duration of the hospitalization. So here is the methodology. This current study used the data from the NSOSO 75th round. The binary logistic regression was used to explore the association of the predisposing, enabling, and the need factors with the utilization of the health services. Now I come to discuss the result and discussion. Majority of the study population is comprised male. 54% of the elderly are male and 46% are female. And majority of the elderly people belongs to the 60 to 69 age group. And more than half of the elderly people are literate. And majority of the elderly people residing in rural areas, almost more than half of the elderly people residing in the rural areas. And majority of the study populations belongs to the other backward classes, and they are from the Hindu religion. Economic dependence of the participants. Majority of the elderly people are economically dependent on their families or the other members, and the major source of their finance is the household saving or income. Now, majority of the elderly people in my study are suffered the chronic non-communicable disease. Almost half of the elderly people are suffered a non-communicable disease, followed by the others disease and the communicable diseases. And more than half of the elderly people are not covered any health insurance coverage. And in my study populations, almost half, more than half of the elderly population don't require any kind of surgery for their health issues. Now this is the results of the logistic regression. From this logistic regression, we see that the sex, the place of residence, the religion, caste, education, the monthly per capita expenditures of the individuals, the economic dependence, and the disease profile like communicable versus non-communicable, and the region plays a significant role to determine the choice of the healthcare utilization. So the analysis shows that among the predisposing factors, the sex, the caste category, the religion, and education turn out to be most significant to determine the choice of the healthcare of the elderly. Elderly female are more likely to avail the private healthcare services as compared to their male counterparts. And the caste category of an individual also has an impact on the choice of the healthcare services. And the elderly belonging to the other backward caste and the other communities are more likely to use private healthcare services over the public as compared to the SC/ST counterparts. Among the enabling factors, the impact of the household size on decisions making coming to be most significant factors to determine the choice of healthcare services. The analysis reveals that higher is the number of family members in an elderly, lower the utilization of the private health services. It may indicate that the support or caregiving of the elderly population imposes an economic burden on families. In health system, where the out-of-pocket money is one of the most predominant source for meeting medical costs, the opportunity to reach and obtain appropriate healthcare services are constrained by the ability to pay. And my study finding also reflect the same thing, that the elderly people having lot of family members tend to prefer the public health facilities over the private because of the financial reason. Monthly household income per capita also play a significant role to determining the healthcare utilization across all the region. The analysis reveals that the likelihood of choosing private hospitals over the public one increases with the increasing monthly per capita expenditures. Economic dependence also determine the choice of healthcare utilization. The economically independent elderly people are more likely to utilize the private healthcare services than their public health facilities. The analysis also revealed that the choice of hospitalization varies across the region also. In the southern region, western and central region, the utilization of the private health services is higher among the elderly as compared to the public services. But on the other hand, the utilization of public services is about 3 times higher in northeastern region as compared to the private facilities. This is maybe due to the non-affordability of the people belongs to the northeastern region. There may be some other reason also, because in the northeastern region there exists an economic backwardness. So due to the non-affordability of the private healthcare services among the people belonging to the northeast region tend to prefer the public hospitals. There may be some other reason also. Maybe there is some implementations of the government program in Northeast India tend to expand the coverage of health insurance in the public sector. So for this reason, maybe the people belongs to the Northeast region are more likely to use the public inpatient services as compared to the private. Among the need factors, the elderly having non-communicable diseases and other diseases are likely to avail the private health services over the public one. Usually, the presence of the non-communicable disease involve higher and prolonged spending and increase the financial burden of the aligned persons and their families. Under these circumstances, people having non-communicable disease are expected to prefer public over the private healthcare utilization. But my study reflects the opposite scenario. This is maybe because of the unavailability of the required specific services in the public hospital. So the elderly people having non-communicable disease tend to prefer the private hospitalization over the public. The analysis also shows that the likelihood of choosing public hospitals over private increases with the increased duration of the hospitalization. As the duration of the stay in the hospitalization increase, the people tend to prefer the public hospitalization. This study also shows that the need for surgery and the private hospitalization have a positive association to determine the choice of the private hospitalization. It is worth mentioning that among the all region, the southern region closely follow the Anderson health behavior model among all the enabling and need factors, which turn out to be significant. So now I come to discuss the conclusions part. The finding of the study shows that public sectors has not been a choice for inpatient care for the elderly population across the Indian states. It established that apart from the financial factors, there are some socio-demographic factors as well as the need factors, which also plays an important role to make a decision concerning the healthcare utilization. So by and large, there are some also geographical pattern. They also explain the state differentials in the utilization of 2 separate healthcare services, private versus public across the country. So the public hospitals need to be equipped with the state-of-art technologies to ensure better treatment in the case of the critical illness and surgical needs. Because people, there is a mindset that when they have some chronic disease, they always tend to prefer the private hospitals as compared to public because the better facilities are not meeting the requirements in the public hospital. So they always try to go the private hospitalization, although the out-of-pocket expenditures in the private hospital is too much costly. As a vast majority of the older population in India are economically dependent. So the utilization of the private health service is not all viable to them. So there is a need to prioritize our efforts towards the strengthening public health infrastructures. There is possibly a need for bringing about regulation in healthcare spending also. However, compromising the quality of the healthcare, there is a need specialized focus on the public health sectors in across the different region also. Because in our country, bears different characteristics having varying needs and problem. Because the choice of utilization of healthcare among the elderly varies across the region also. So the health policies need to be sensitive to the specific regional requirements. In this respect, special attention needs to be given to the backward regions of the country like Northeast region. Thank you.
Thank you, Chunki, for a very interesting presentation, making use of the National Sample Survey data. We will take up the questions and comments later. So we will move to the second presentation by Mr. Shobhit Srivastava on socio-economic inequality exists in one-person households among older adults in India. Okay, Shobhit, your PPT.
Yes, sir. Am I audible?
Yes, you are audible, but where is the PPT?
Oh,
Yeah.
yes, sir. Wait for a second. Okay.
Okay, please start.
Yes. So, wait for a second. Good afternoon to all of you. I'm Shobhit Shrivastava, a senior research fellow from IAPS Mumbai. I'm going to present my paper on the topic entitled Does Socioeconomic Inequality Exist in One-Person Household Among Older Adults in India? Evidence from National Family Health Survey 2015 and 16. Coming on to the introduction, among a rapidly aging population, living alone is considered a living arrangement with various disadvantages. Changing modern socioeconomic circumstances and living and rising living standard affected housing option and conducted to the present day prevalence and perception of solitary living. Overtly, the waning of multi-generational living arrangement and as increasingly aging population resulted in the growth of one-person household among older adults. The burgeoning literature suggests that the people who live alone in their later life may be more vulnerable in terms of socioeconomic factors. However, other studies also argue that increased level of income enable the older adult to afford more privacy in the form of solo living, and that increases with the rise of individualism and the decline in intergenerational values. Previous studies that focused on educational attainment as a proxy for economic resources found that those with lower education and those with more strained resources were more likely to live alone than their counterpart with higher education. A cross-sectional study found that there is a higher proportion of older adults living alone, and the reason reported as not having children or children living elsewhere, most likely due to migration or marriage. It is also found that currently married women in rural areas whose husband might have migrated were more likely to stay in OPH. So, coming out of the need of the study, since there is a scarce literature on older adults who are solo living in India, we in this empirical study assess the association between older adults living in OPH and a variety of socioeconomic factors separately among poor and non-poor older adults. The study hypothesized that there are no socioeconomic differentials for living as OPH among older adults in India. Coming on to the methods. So I've used data from National Family Health Survey 2015 and 16. The analysis of this study is based on household data file, and data were restricted to the households aged 60 years and above, which means at least one person in the household was 60 years or older. The outcome variable was OPH, whether the person was living as alone in the household or not. Statistical analysis, univariate, bivariate, and multivariate logistic regression analysis were performed to find the factors associated with OPH. Additionally, box-top decomposition analysis was adopted to find the contributions of various factors for SES, that is socioeconomic status related inequality for one person household among older adults in India. So coming out to the results, it was found that almost 12.7% of older adults who were from the poor category reported that they were living as OPH, that is one person household, whereas only 3.8% of older adults from non-poor category reported that they were living as OPH. Overall, 7.4% of older adults in India were living as OPH. This is a concentration curve. It depicts that the higher OPH was found among those older adults who were from the lower socioeconomic strata. The value of concentration index was 0.38 as a minus category. That means it was concentrated more among poor. The concentration index for OPH among older adults were more concentrated among poor older adults across the states in all states, almost all states, but the values were highest for Manipur, followed by Mizoram and Haryana. The decomposition analysis results depicted that about 33.6% of socioeconomic status related inequality was explained by marital status of older adults for OPH, followed by place of residence and gender. However, a small proportion of socioeconomic status related inequality was explained by educational status among older adults as well. Coming on to the limitations, the study had certain limitations also. The decision to live as OPH neither starts at the 60th birthday, nor does the exogenous event lead to OPH arrangement. However, with the present data, it was not viable to extract the information that when the older adults start living as OPH. Moreover, since our findings are not based on the cross-sectional data, we could not examine the changing structure of household over time and how does it affect the OPH structure. Coming on to the conclusion, our research provides insight to identify the older adults living in OPH and their socioeconomic inequality, which have significant policy implication. Older adults who are poor, women, never married, and living in rural areas need greater care and attention with a stronger public support system. Therefore, interventions can be designed to ensure the overall well-being of older adults living alone. In the absence of any family member and kin support, initiatives should be taken to reduce their economic and social vulnerability. Further, never married older adults are often overlooked in the policy and academic discussion that need a policy focus. Thank you.
Thank you, Shobit, for sticking to the time and highlighting some of the major issues related to the one-person households, making use of the National Family Health Survey. And it also shows that NFHS can be used to analyze various issues related to older adults, not only on maternal and child health care. Now we move to the third presentation from Mr. T. Muhammad on the association of socio-economic and health-related factors with the preference to separate living among older adults. Okay. Over to Muhammad.
Yes, good afternoon, everybody. Here, I would like to present my research on socioeconomic and health determinants of preference of separate living among older adults. It's a cross-sectional study. So coming to the introduction of this topic, as all we know that the living arrangements among the older population form a basic pointer to the care and support of older adults in India. and living with extended kin is clearly differentiated from living separately. And it is also shown in the Lassie Wave First, which is recently released, that reveals that the older people aged 60 and above, they are living alone, and it consists of 6% of the total 60 plus population, and there is a substantial gender difference, sex difference in the proportion of living separately, which is living alone, which includes 2.5 among male and 8.5 among older women. The living with spouse also shows that there is a higher proportion, which is 20%, which has increased in recent years. So just sticking to the findings and the whole study picture, I just say that this study attempts to understand the associations between socioeconomic and health-related variables with preference for separate living among older adults in India. So, but we are using the data of BKP, which is a little old, and we propose to study with Lassie data. So here we employed bivariate analysis and probit regressions on a sample of 9,540 older adults. As we know, in the probit model, the inverse standard normal distribution of the probability is modeled as a linear combination of the predictors. And also the cumulative standard normal distribution function phi is used as to model the regression function when the dependent variable is binary. So that here we assume that estimation of y given x equals probability of y equals 1 given x equals that equals the phi of, or the probability, cumulative probability of beta 0 plus beta 1 x multiplied by x. So here the outcome variable we generated was using the question, what is your preferred living arrangement? And we made it binary or dichotomized it with seeing the separate living, which includes living alone and living with spouse, and all the other living arrangements as co-residential arrangements. So coming to the results of the study, living alone or with spouse, which the proportion is 21% among 60 plus population, and 79% of the older adults are co-residing with their family, with their spouse, and with their children and other relatives. Coming to the reasons for this separate living or living alone or with spouse in their current living arrangement, it shows that most of the older adults who are living separately reported that their children are away, or their children they don't have children, and then there are some reasons which are mentioned as family conflict or independent or economically active perceptions of these older adults, which also make them living alone or living separately. Coming to the multivariable probit regression results, as all we see here, the significant results of the marital status, which is positively associated with separate living among older adults, shows that those who are married, they are preferring more for separate living, whereas those who are highly educated, they also prefer for separately living. And then the place of residence is showing a negative association with separate living, where the rural older population are preferring more for separate living. In urban areas, they are already fine with, maybe because of the solo living already they are in. And another significant, strong predictor of this separate living is as we see in the importance to the family, where the reviewer asked the question that how important you are feeling to your family, then the respondent says somewhat important or not important, and the positive association shows that those who are feeling important in their family, they don't prefer for the separate living. But those who are not important, they always prefer, more likely to prefer the separate living. Whereas the availability of children, it is also showing a significant result, which is showing a negative association, where those who are having no children or having lesser children, they always prefer separate living, whereas those who have a higher number of children, they prefer more co-residential living. So the characteristics including education, marital status, and place of residence are found as significant as we've seen. And then the preference for co-residential arrangements also is associated with a feeling of importance within the family. Availability of children is found to be negatively associated. This confirms the demographic availability hypothesis, which is we see in the literature that suggests that the availability of adult children is an important determinant of living arrangement among older individuals. Coming to the economic and health related variables and its association with separate living, we see here that the asset ownership, where the older adults who are not having any assets, they don't prefer separate living because they don't have any assets and they are more dependent on their children. Whereas the working status, where the employed older adults are more likely to prefer a separate living or living alone or living with their spouse. Whereas the money contributed to the household expenditure, which shows that those who have contributed or those who have independent income, they are more likely to prefer a separate living arrangement. Whereas those who are facing any sort of violence, elder abuse, they are more likely to prefer separate living. And then once we come to the health variables, that also shows that those who are poorly healthy, those who are unhealthy, those who have lower poor self-rated health or lower functional abilities, and those who have more difficulties in their functionality, they prefer more separate living. They are more likely to prefer separate living. So coming to these findings, we see that this separate living is positively associated with employment and ownership, whereas contributing money to the household also is a positive factor which determines this separate living preference. And it supports these economic association of these economic variables supports the purchase of privacy hypothesis, suggesting that income as the primary factor that determines the propensity to live alone, which they see as a reflection of economic demand for privacy. And these older adults who have much economic or social resources, they sometimes prefer their living alone or living with spouse only due to their having more privacy or more independence and authority. Whereas better self-rated health and functional difficulties were negatively associated with separate living, as we have seen. And this facing any type of violence also is a positive factor. So to conclude, here, as we have all seen from the results, we can see that this physical proximity to kin and health conditions, in addition to economic conditions, substantially determine the swing towards separate living among older adults in India. So attention to be paid on the demand for specialized care and health services among older adults who are living both in co-residential arrangements and separate ones, and also those who are having no children or those who are having children but they are away from them. And there should be some policies which promote them for making it proximate to these older adults and giving them much more care and support. That's all. Thank you.
Thank you, Mohammed, for a very interesting paper highlighting the gradual changes happening in India with regard to the living arrangements and separate living and its influence or relationship with the economic dependency, physical condition of the elderly, as well as the violence or abuse that they have experienced, as well as the availability of children to take care of older parents. And I think you have highlighted one of the important issues in Indian context. Now we will move to the next presentation by Paulami Burman on living arrangements and treatment seeking behavior among elderly with locomotor disability in India. Over to Paulami.
Thank you, sir. Am I audible?
You are audible. Yeah,
yes.
You are audible. Yes. Please go ahead.
Good afternoon, everyone. This is Paulami Burman, and I'm presenting my topic, living arrangements and treatment-seeking behavior among elderly with locomotor disability in India, a comparative study. So, living locomotor disability, that is the restriction in the movement of the limbs among different type of disabilities, this is the most prevalent one, affecting the population of all ages as well as the elderly in India. Now, as we can see, India is experiencing demographic transition and older individuals are living with an increasing life expectancy. The matter of concern is whether demographic aging couples with the burden of disability, because several studies have found no denying fact that these added years to life often accompanied by chronic physical impairment. These older disabled persons are the largest deprived group in the world, and India is not an exception. The responsibility for the care of the disabled elderly is generally left to the families, few voluntary organizations, and to the government. As per the previous study, it has found an available spouse provides all much needed care to an older adult requiring care. When the spouse is absent, the children are likely to provide all care more than other relatives or friends. Also, the older persons who experienced spouse loss were at greater risk of not seeking treatment for reported disabilities. In this regard, the treatment-seeking behavior of disabled older persons by their living arrangements is a complex phenomenon and remains largely unexplored in India. Keeping this perspective in view, we specifically aimed to work out a comparative picture of living arrangement by different background characteristics, tried to explore the treatment-seeking behavior and type of caregivers of the elderly with locomotor disability in both states, Uttar Pradesh and Kerala. We have selected these two states, which are at varying stages of health transition, also vary in socioeconomic and demographic conditions. According to Census 2011, Kerala has the maximum proportion of elder persons, and according to NSS 76 around, Uttar Pradesh has the highest number of elderly with locomotor disability. The greater life expectancy at birth, aging index, and the percentage of older adults confirms the advancement of Kerala in demographic aging and transitional process. Now the question is whether this advanced phase contribute the changing disability profile among older persons. This study is based on the National Sample Survey 76 around data on disabled persons in India, which is the most recent one. And we have used bivariate analysis to show the person distribution of living arrangement, to show the person distribution of elderly seeking treatment and type of caregivers they have for their disability across the different living arrangements. Also, binomial logistic regression is used to predict the odds of having treatment according to the living arrangements across the states. Coming to the findings and result, here is the table for person variation in the living arrangement among elderly with locomotor disability by different background characteristics in UP. And this is the same for the Kerala. And comparing these two tables, I have here some key findings. Most of the elderly living alone with locomotor disability belong to the age group 60 to 69 in Uttar Pradesh, while 70 to 79 in Kerala. We observed that the percentage of older women live alone higher than older men in Uttar Pradesh. However, this gender discrepancy of living arrangement increased for Kerala. Most of the living alone elderly are illiterate, widowed, belong to the lowest wealth quintile, and living in the rural areas in UP and Kerala. The elderly with locomotor disability living with spouse and family found in highest MPC quintile. So this is the graph of predicted probability of living arrangements by background characteristics in UP. We found that in UP, elderly with locomotor disability aged 80 plus years have higher chances of living alone, and the 60 to 69 age group has higher chance of living with spouse and family. And now compared to the men, older women have higher chance of living alone. And interestingly, we observed that women are more likely to live without spouse compared to the men. As compared to the UP, the chances of living alone higher for the 70 to 79 age group in Kerala. Also, older women have higher chance of living alone as well as living without spouse as compared to the older women in UP. Now coming to the treatment-seeking behavior and the type of caregivers among the elderly across both the states, here is the table for binomial logistic regression analysis of healthcare utilization by living arrangement across both the states. After adjusting other variables, here we can see elderly living alone is the least likely to use healthcare facilities, but elderly in Kerala use more healthcare facilities compared to the elderly living alone in UP. Elderly who reside with their family members are more likely to use healthcare facilities in UP, while same we can see for the elderly living specifically with their spouse in Kerala. This is the table for person distribution of treatment-seeking behavior and type of caregivers by living arrangement among the older adults in both the states. The elderly living with spouse and family showed to have maximum utilization of healthcare facilities in UP as well as in Kerala. Most of the elderly living alone seek treatment for their disability. However, these elderly do not acquire aid as much as needed. No elderly living alone has hired institutional caregivers in UP. On the other hand, the proportion of hired or institutional caregivers are found to be higher in Kerala, and also the proportion of spouse as caregiver reported to be high in Kerala than Uttar Pradesh. While living alone spend an average amount of rupees 250 on their medical treatment in UP, at the same time, it is almost 4 times higher in Kerala. Now coming to the discussion, in both the states, older persons of 60 to 79 age group with locomotor disability are living alone because of the increased life expectancy. Findings from the current study have shown the feminization is much more prevalent among the elderly living alone with locomotor disability in Kerala because of the increased life expectancy among women. Elderly who lives with their spouse and other family members belong to the highest quintile of MPC, which means they get more healthcare resources than those who are living alone. Economical security of the elderly with disability emerges as a major issue in the absence of co-residence with other family members. With respect to the treatment-seeking behavior, elderly who are living alone are less likely to seek treatment in both states. But in Kerala, the majority of elderly with locomotor disability who lives alone seeks treatment usually spend more money for their medical treatment compared to the elderly in Uttar Pradesh. The expenditure varies significantly among the states. The plausible explanation for these discrepancies may be first, differential in the cost across the states, may be due to the differential in the cost of medicine, informal fees, and the variation in the prices across the states. And second, a significant proportion of treatment in Kerala was conducted in district level hospitals, whereas most of the treatments in UP were conducted at the sub-centers and PHC level hospitals. With respect to the type of caregivers across living arrangements, proportion of spouse as a caregiver and the proportion of hired or institutional caregivers are found to be higher in Kerala compared to the UP. Presence of spouse has ensured the care availability to the older adults with locomotor disability requiring care. The non-familial sources of caregiving were steadily becoming visible among the disabled older adults living alone in Kerala. In both the states, elderly living with the other household members play a very crucial role as a caregiver for them, although the percentage is higher for Kerala. The other household members category includes children, son-in-law, daughter-in-law, and grandchildren. And this exemplified the intergenerational bonding with their family in India, ensuring the care availability to the disabled older adults. One peculiarity in these findings was that even though older adults with locomotor disability lived alone, the proportion of care and the support they received from their family was still higher in UP than the elderly from Kerala. It is difficult to conclude whether older adults actually received all this care when they are living alone with their disability, or whether they chose not to report their family's care deficit, as it is taboo to reveal such issues in India. Now, the strength of this study is this study shows Kerala is in advanced phase with respect of healthcare utilization, and it advances the knowledge about treatment-seeking behavior and caregiving to the older adults with locomotor disability using a national level data set. In this study, the pattern of treatment-seeking behavior is in expected direction as India is entering the advanced phase of health transition and demographic aging. But it has been substantiated that although Kerala is in advanced stage of health transition compared to UP, still the state is somehow lagging behind to some extent in the process of healthcare utilization. These demand intervention of better health programs, medical care, various health insurance schemes for the disabled elderly. Also, efforts are necessary to ensure that those disabled older adults with locomotor disability who need care are not disadvantaged on account of their living arrangements. These are some references. Thank you.
Thank you, Paulami, for highlighting the issues with regard to the institutional caregiving and the locomotor disability and issues, and also highlighting the big variation from UP between UP and Kerala. Now we'll move to the fifth presentation by Dr. Harihar Sahu on health issues, healthcare utilization, and healthcare expenditure among elderly in India, a thematic review of literature. Over to Dr. Sahu.
Very good afternoon to everyone. So I am going to present on the issues of health as well as healthcare utilization and health expenditures among elderly, and this paper is derived from a project which is running in the institute that is integrating aging research with policies and programs in India and funded by UNFPA. And it is my privilege to present the paper on behalf of my co-authors. As we know that the population aging is a worldwide phenomenon and experienced by almost all the countries of the world and reflects socioeconomic and health achievements. According to World Population Prospects, so globally population aged 65 years or over increased from 6% in 1990 to 9% in 2019. And we know that the share of the aged population in India has increased from 6.5% in 1981 to 8.6% in 2011 and would further increase to 10% by the forthcoming census. The increasing feminization of aging, widowhood, and rapid growth of population aged 60 years and above are the emerging as important issues for research on aging in India. Apart from that, the agenda of Sustainable Development Goals 2030, that population aging are particularly relevant for the goals on eradicating poverty, ensuring healthy lives and well-being at all the stages, and full and productive employment and decent work for all, which is on SDG 8. As apart from that, the aging population is associated with itself like frailty, comorbidity, disability, poor health, leading to higher healthcare utilization and high out-of-pocket expenditure. Health status of an individual is generally determined by many factors like individual behavior, family structure, and their relationship, health systems, and health outcomes. Although the medical service utilization patterns among older persons have steadily increased in the recent years, so there is a paucity of research work and evidences related to elderly population in India. In order to achieve the goals pertaining to the healthy aging and a reflection of momentum generated around the issues of population aging in the Indian context, assessing the status of health issues was thought to be important and formed the basic research question. The broad objective of the study is to synthesize the empirical research studies on health issues of elderly, status of healthcare utilization, and expenditure of elderly in India. Specifically, this review is an attempt to understand the research gaps in the existing literature and suggest further scope for research and for policy implications. So in the thematic review, a search strategy was adopted to find the comprehensive literature on health issues, healthcare utilization, and expenditures among elderly in India. The review was performed to identify all research studies from Scopus, PubMed, ResearchGate, Google Scholar, and from internet search by various combination of keywords and synonyms of closely related words were used to identify the potential articles and references in the study. It was also used cross-referencing to check the references cited in the review papers and articles identified through the search engines and to find additional relevant papers. So the review employed a systematic research on all relevant studies, meeting the specific inclusion and exclusion criteria. The inclusion criteria was limited to the peer-reviewed national and international journals, following the guidelines pertaining to the inclusion criteria. The relevant literature was chosen to represent articles specifically published during 2000 to 2020. Conference proceedings, posters, oral presentations have been excluded from this study. So here in this figure, the selection of studies for the systematic review of health studies, healthcare utilization and health expenditure for elderly in India. So initially 2,595 articles were identified through database and website screening. After removal of duplicates and conference proceedings, the search strategy yielded 2,404 potentially relevant studies, and out of these 2,329 studies were excluded after primary screening for meeting the inclusion criteria. Finally, 75 studies were retrieved and read and for more detailed information, and 72 studies were included for final analysis and systematic review. So coming to the specific themes of the study which we have identified, the first is health issues and elderly of the health issues of the elderly population. So an increase in the life expectancy among elderly increases the risk of incidence of NCDs, and it further leads to morbidity as well as disability. Mostly age-related disorders, including life-threatening disease like cardiovascular disease, cancer, diabetes, infections, as well as certain chronic disabling conditions affecting vision, morbidity, hearing, and cognitions. So about 80% of the older adults have at least one chronic disease, and 77% have at least two. So among elderly in India, the prevalence of stroke is about 2%, and chest pain was 20%, asthma is 11%, and so on. So from here, if we'll see that, so as the population, the age progresses, the proportion of NCDs is substantially increased over the ages. So this is already we have seen. Further, if you see the several countries, but this graph is derived from this says. So we can see that as over the ages, so how the severity of hypertension has increased. So coming to these chronic its risk factors, we can see that the several socio-demographic characteristics, biological risk factors, and behavioral risk factors plays an important role. And the major risk factors like tobacco use, obesity, physical inactivity, as well as alcohol consumptions are the major risk factors. Further, if you see that the obesity, which is on the rise in India due to the combination of readily available high-fat content food products and increasing sedentary lifestyles. And of this, we can see that about 2/3 of the elderly getting no physical exercise, and lack of exercise that increases with age and was significantly more prevalent among females than males. So one of the major issues that which has emerged under this head is that the very few studies have undertaken on clustering of risk factors as a determinant of NCDs. Although if you'll see that the reported burden of chronic illness is high, so many NCDs affecting older adults remain undiagnosed. So due to lack of access to health education services and financial resources. So unmet need was more prominent with respect to stroke as well as the chronic lung cancers, about 1/4 for the hypertension, arthritis, angina, like diabetes and asthma. Apart from that, if you'll see specifically the care needs for these chronic diseases, so many of the less and middle income countries that continue to remain focused on the treatment and management of acute infectious illness and on the provision of MCH services. So many countries are not adequately equipped to effectively manage NCDs, either in the primary healthcare sector or in terms of access to specialty or tertiary care. So if we'll see that the inadequate healthcare systems are likely to have lower rates of diagnosis and treatment of NCDs and a rising disease burden from these conditions. So apart from that, the NCDs, so another major problem which has arisen out of this review is that the musculoskeletal disorder is among the elderly are important. So as a result of which it is a major cause for physical disability in elderly population, and it rises with age. It influences the ability to continue the independent living, then either sight or hearing the impairment. So apart from that, this MSDs, that is the self-reported arthritis, is roughly around 1/5, and system-based arthritis is 1/4 among elderly in India. The specific factors which are responsible are higher body mass index, like that also sleep duration, as well as the vigorous physical activity, chronic lung disease, hypertension, stroke, chronic kidney disease, chronic digestive disease, as well as alcohol consumptions are some of the risk factors which have been found from several literatures. The burden of these fragility fractures that also increase in years to come, and that translates into higher healthcare costs. Apart from that, the vitamin D deficiency and low calcium intake is widely prevalent that impact on the bone health. So government agencies or ministries of health then need to take bone health programs as a priority and initiate a media campaign to spread awareness about lifestyle issues. Coming to the disability and immobility, we can see that the increased risk of multiple comorbidity in elderly population that lead to disability, and elderly which are disabled are about 21%, and wherein 18% for males and 23% females. And multiple disabilities have been reported among 12% of the elderly. With respect to the mental illness, so dementia, depression, Alzheimer are the most common mental health problems among elderly, and some of the problems like psychiatric morbidity, stress, anxiety, sleep disorder are issues. So chronic diseases like restricted mobility, behavioral or elderly abuse, isolation, loss of income are some of the identified major risk factors for the depression. Apart from that, the breakdown of the family values and framework for family support due to societal modernization further has a detrimental influence on the psychological health of the elderly. Even though depression is the common psychiatric disorder, it is often perceived as a part of aging rather than treatable conditions, and hence misdiagnosed and undertreated, which is one of the important issues which has emerged from this review. Coming to the multimorbidity, so association of the multimorbidities with many adverse health outcomes reduces physical functions and poor quality of life, that increased use of inpatient as well as ambulatory care. About 1/4 of Indian men and Indian women in the age group of 60 to 69 years reported multiple chronic conditions, and 26% of the elderly in India have a higher chronic health conditions, with 16% had multiple morbidities. And persons with one condition that increased from 8% in 18 to 29 years ages to 57% of 80 plus. And there are several studies, and there are several differentials with different kinds of comorbidities as well as the multimorbidities. With respect to these healthcare services for elderly in India, we can see that the absence of separate healthcare services for elderly, and that poses services are wherever the services are available. So uptake by the elderly is low because of the lack of awareness or health promotion or community reach. So in that circumstances, so public healthcare utilization for elderly that has increased from nearly 9% in case of hospitalization and 18 nearly 19% in outpatient care during 2004 to 17-18. So health seeking behavior, so untreated morbidity and health seeking behavior that depends upon several factors like availability, affordability, as well as accessibility of the services. And apart from that, the responsiveness and fee charged by the healthcare service provider, as well as long waiting time, plays an important role. So apart from that, there is a large variation with respect to the economic conditions and decision makers in the family, severity of the illness, cost of the treatment, and the source of the information, living arrangement. All these factors plays an important role. While a pre-existing morbid conditions, a notable proportion of elderly not utilizing the available health services, and there is a large disparities pertaining to the economic status with also the pension support, social caste, the insurance coverage, and healthcare personnel can also keep record for the overall health conditions of the elderly, and they may provide timely feedback and support from distant facilities. Apart from that, so another emerging issues which is emerged, that is the gender-based disparity in healthcare utilization. So we can see that the higher prevalence rate for multimorbidity in women compared to men, but older women face a higher risk of chronic illness and disability and spend larger proportion of their lives in poor health than older men. So, but a far greater proportion of men are hospitalized compared to the females. So overriding the other determinants of healthcare seeking and treatment, so research-based findings that highlighted that the gender-based disparity in healthcare utilization among elderly, while older women in general are at risk for poor health, and studies show that aged widows is particularly the disproportionately vulnerable with respect to disability, illness, and poor health. Coming to the inpatient and outpatient healthcare expenditures, so due to this rise of the burden of disease among elderly, their footprint
Dr.
in public
Sahu?
facilities. Yeah,
Dr.
2 more
Sahu?
minutes. Yeah,
Please.
Yeah, 2 minutes. Is it okay?
Please go ahead. Conclude.
Yeah. So the proportion of those who attend hospitals that increased in old people compared to those who attend hospitals among the general populations. So with respect to this out-pocket and catastrophic health expenditures, so as there is a lack of comprehensive health insurance schemes, so increased choice of healthcare seeking in private health sectors that affect healthcare equity in India, and there is a prevalence of catastrophic health expenditure is higher among the households with older people, households which are headed by the female members, and rural households. Coming to conclude, so in order to address the geriatric healthcare needs effectively, it is crucial for the public policy in developing countries to be grounded in an understanding the vulnerabilities faced in old age, not as a product of old age alone, but rather caused as an interlocking system of inequality with special impetus to gender. So high spending coupled with absence of insurance coverage by the elderly, particularly those belonging to lower socioeconomic strata. So thus recognizing the determinants of health service utilization and health expenditures are essential for targeting health financing policies to establish equitable healthcare delivery among Indian elderly. So further steps are required to incorporate the use of ICT, information communication technology, for better reporting and focusing on health promotion and addressing health literacy in communities. and research gaps in understanding the relationship between living arrangement and healthcare utilization and horizontal equity of healthcare utilization in the matters of better healthcare coverage and eliminating the healthcare disadvantages needs further exploration. Thank you for your attention.
Thank you, Dr. Sahu, for a very systematic review of studies on health issues, geriatric healthcare, and health-seeking behavior based on a review of 72 published studies, and also highlighting some of the issues related to the existing research gaps in case of geriatric healthcare. Now we will move to the last presentation of this technical session, that is by Dr. Deepthi Govil on working women and elder care, a qualitative perspective. Over to Dr. Deepthi.
Thank you, sir. Yeah, just a minute. Yeah, so good afternoon, everyone. So today I will be presenting a paper on working women and elder care. So this study was actually conducted under a very large project, which is the Integrating Aging Research with Policy and Program in India, which was funded by UNFPA, Delhi. So I'll be giving you a little glimpse of what actually we have found from it's a very small study which we have conducted, but still the findings are very much relevant because the data is not very much available on this particular issue. So, yeah. So I'll give you a very small brief backdrop because I want to pay more attention on what we actually have found. So let us see, the family members, especially women, are the main providers for the care and support for the elderly, which we have seen across the generations and over the years. And with the advanced education attainment and renewed employment opportunities, elder caregiving has become a serious concern, which has affected both elderly as well as women caregiver due to various reasons. So therefore, this paper actually aimed to explore the elderly caregiving process, challenges, and coping strategies adopted by working women to attain to multiple roles and responsibilities. So to address this particular objective, in-depth interviews with 48 respondents, out of which 22 were the caregivers, care providers, and 26 were the elderly care receivers from 25 multi-generational households were conducted in the slums of Mumbai during the November 2019. And we have used snowballing sampling to trace our respondent. And because major constraint which we actually have, major criteria which we have actually implemented is the elderly. We wanted to select the households where elderlies are there with the ADL difficulties. Generally, all the elderlies have certain kind of an ADL difficulties or certain level of ADL difficulties, but we wanted to make sure that we only get the household which have the ADL difficulties and therefore they need caregiving. Okay, so ADL difficulties we included feeding, bedding, dressing, toileting, mobility, etc. And so they were selected. And the caregivers were the people, those who were decided based on the older elderly's report of who provides maximum care. So we have obtained ethical approval. So this survey, this small study was conducted for around 20 days. So we got the approval from IRB of IAPS Mumbai, and it was funded by UNFPA. So we translated the guidelines into Hindi and Marathi, and then the interviews were audio recorded and which were later translated, transcribed verbatim. Some of them were in Marathi, and many of us are not aware about the Marathi, so we tried to translate them into English. So, and the transcripts were analyzed using the NVivo software. So here are the few findings about the study. So let us see the profile of the respondents first. So the caregiver and the care provider, care receiver and the care provider. So average age of the care receiver was around 73.5 years, whereas the average age of the care provider was 40 years. So nearly approximately same proportion of the elderly as well as the care provider, which is 60%, were neither educated or studied up to the primary or studied up to the primary class. Nearly 60% of the elderly were widow and 90% had difficulty in mobility. And majority of these elderly were financially dependent on their children with no social security. In case of the care providers, which is applicable, this characteristic is applicable for care receiver as well as provider. 50% of them followed Hindu religion and 21% followed Buddhism, and 73% of them were staying with their in-laws. Means these care providers were daughters-in-law of the family. Another important part which I would like to mention, that we planned this study both in the slum and the non-slum area, but because of the limited response from the non-slum areas, we could not, we hardly could interview very few people from the non-slum areas. So let us look at the results. So so first I would like to mention about the care perception, what actually people feel, what should be the care perception. So the elderly felt that caring for the elderly includes providing them with a proper diet, specifically ailment-specific diet with a various restriction. They felt that they should be asked for their preference for the food, and food should be given on time, and it should be simple home-cooked food with less oil. These sort of preferences were more among the females elderly than males. Male elderly were very much interested only in getting the food, that's all. And the care providers also mentioned that we should provide them the suitable food as per their health status. Apart from that, providing necessities and helping them with the daily chores were another important component which came out, that is the care should be given to the elderly. So the elderly man, I'm emphasizing here that the elderly man felt that care is when someone washes their clothes, help them to go to the washroom, provide them with the hot water for the bathing. As many of them had the mobility issues and needed support for the day-to-day activities, especially in the movement from one place to another. Care providers also felt that the elderly should be kept clean. Very interestingly, the result which we have got from the elderly man, when they emphasized on the necessities for the necessities and helping them with the daily chores, it actually reflects the fact that the men in India are primarily dependent on women for their every basic needs. Apart from that, for economically dependent care as perceived by those who were economically dependent have here restricted to the providing basic needs as well as helping for the accomplishing basic chores as well as eating. But for those elderly who were economically independent, care was more intangible. Their concept of care is more like providing companionship, listening to them and making them feel wanted. Just a small quotation I would like to give, and this is the only quotation I will be giving. The 78-year-old retired government servant said that people at home and outside should at least smile at me when they see me so that I feel wanted. Apart from that, their economic condition or their status allowed them to negotiate with their status, at least at home, as well as to get the ear. The care providers, which are primarily daughter-in-laws, also felt that the elderly need friends for companionship. Now let us see what the care needs they were actually having. Okay, that was a perception and this is the need. So emotional needs were articulated mostly by the elderly women, and many times it was just a subtle indication about their wants and wishes. Loneliness is something that haunts these elderly, coupled with the fact that they are widowed and younger generation has little time for them. They long for somebody with whom they can speak. Few of these elderly women even waited for their used to wait for their sons to come back and have dinner together, even if the sons were abusive towards their mother. Apart from that, financial care needs were not expressed explicitly by the elderly, but it was apparent through the observation and the narratives of the caregivers and the care providers that it is the most important part. It is also important to mention that most of the properties, be it in the slum or in the high rise, were in the name of elderly, which might have influenced how and what kind of care they might have been received or kind of an opinion which they are forming. Apart from that, most of the elderly men and women required help with daily activities, be it cooking, bathing, or going out. Mobility issue made them vary, and some needed assistance to go to the toilet even. It also made them confined to their houses, and the care provider used to bring medicine from the store even for the health care and give them on scheduled time. Apart from the medicine care, elderly were also had a specific diet requirement like bland food or less oily food and limited and kind of a thing, and which were fulfilled by these care givers or providers. Okay. Then apart from that, if we see specifically, daughter-in-laws were the main caregivers, followed by the daughters, as well as some of the people, those who were married, the spouses were the another caregivers. Grandchildren were of the great support in the absence of care provider when they were they went for the work. Now, this was the daily routine. Let us discuss about the daily routine of the caregivers and the care providers. So the daily routine of the care receivers either encompasses a lot of leisure time in which they eat, sleep, chat with their peers and roam around, or it is spent in helping in the household and working along household work or with the spending time with the children. Apart from that, the daily routine for all care providers is almost identical. It leaves no space for the leisure activities. The day starts early, wherein they complete making food for the family, wash utensils, clothes, serve breakfast to the all family members, and they leave to job. After returning home from work, they have to make dinner, wind up all the leftover tasks, and prepare the same grind for the next day. This general routine gets minor modification if they have a small children whom they have to prepare for the school. If the care provider has a teenage daughter, definitely they help them a bit in the household chores. So juggling between household work, caregiving of the elderly, and the job, the only time they get for themselves is at night before going to the bed. And sometimes during that time, sometimes they watch television or they scan through their mobile phones. Very interesting concept which came out from the study was a bidirectional flow of care and support. Contrary to the popular belief that the elderly are only being recipient of the care and the support, they actually contributed a lot for their family. From taking care of the grandchildren to providing the monetary support to help their household chores. The grandparents actually enjoyed spending time with their grandchildren. They used to take them to the school, bring them back from the school when the mother was at work, and spending time with the grandchildren was kind of a leisure activity for them. The dissimilarities by gender were very much visible for the daily routine activities. The elderly women tried to help in the household work in spite of the health problems, while the male elderly spent their time relaxing relaxing and being hugely dependent on female caregivers for all basic activities. This leads to the concern of a strong gender divide on the care perception. House in the name of the elderly, which gives leverage to the family to spend no money on the accommodation in the city like Mumbai was one of the major contribution which was done by the elderly. And apart from that, those who were getting the pension, many of them were used to use that pension for buying medicine and gifts for their family. Regarding the perception of the care about the caregiving, the concept of filial piety emerged from the study where the caring for elderly, especially parents or parents-in-law, is considered a duty and an obligation. Though the caregiving has overstrained working women, the strong family ties, acknowledgement of the contribution of the elderly during their young days and setting precedent to their children do not let them step back from their duties. Since caregiving was an inevitable part of some of the care providers' life, they took the responsibility with sincerity and commitment. Rather than complaining about being overburdened, they accepted caregiving as their duty towards their ailing parents and parents-in-law. The thought that one day the care provider would become old and helpless further guided and motivated them to take care of their elderly. Caregiving was a sort of the repayment for the help and the support that elderly had provided to the care provider or the family when elderly were healthy. So apart from that, having an elderly person in the house was an essential, as the household benefits from the experience of the aged person. But many of them said that reciprocity from both sides is required if caregiving has to be happy. Now there were few challenges which I want to highlight. There were different difficulties in ambulating, and associated restriction were the most significant challenges faced by the elderly, which subsequently gave rise to difficulties in activities of daily living. Elderly men received help from family to overcome the challenges. However, for few elderly women, the challenges became nightmare with no or limited help. Because of their mobility, they were confined to homes and had restricted socialization. Livelihood opportunity, pension options were limited to few. Hence, money was a major hurdle for those elderly who wanted to seek treatment for their health problems. However, expenses on regular medication and emergency hospitalization put their family in financial distress, forcing these women to women caregiver to work to meet their ends. Lastly, some of the elderly were also subjected to abuse and neglect, and women elderly were more likely to be the victim of neglect, especially from their sons. In case of the care provider, the challenges which they faced were related to demanding jobs and absence of any support mechanism to manage multiple responsibilities of household and caregiving. They rarely got time for themselves to pursue their dreams, visit their families and friends or relatives. These challenges took a toll on their emotional well-being. Most of the care provider complained of frustration and anger because of their truckload of work. Some of the care providers were also tensed about the well-being of the elderly. Because of that, they have to leave the elderly at home and go for the work. They were also negligent toward their physical health and experienced tiredness and dealt with the body aches. Limited healthcare seeking options for them was also a major constraint, because whenever they have any health problem, they had to go to the over-the-counter treatment because they do not have a time to go to the healthcare center, and they have to also compromise on their children's well-being. So there were few coping mechanisms which were adopted by the caregivers and the care receivers. The coping mechanism for both caregivers and care seekers were largely centered around the notion of acceptance of their situation. The elderly accepted that old age would be riddled with health problems, and therefore they should be contented with whatever care and support they are receiving from the family. And they actually waited for their death whenever it can come. Most of the elderly believed in having an active lifestyle to keep themselves healthy, but the gender divide was very much visible in the study regarding the coping mechanism employed by the care-seeking elderly to mitigate the stress. The study further highlighted that elderly employed both problem-focused and the emotion-focused coping mechanism to manage their stress and found alternative solutions to their age-related problems instead of cribbing and feeling distress about that. So they adopted like active lifestyle to deal with the problem, as well as they started spending time with the neighbors and the friends in order to fight the boredom and the loneliness. Similarly, the working care providers also held their responsibilities above the interest of their own self and diligently went ahead with their daily chores of the household work, jobs and caregiving activities. Due to the multi-load of the work and the responsibilities, stress was inevitable for them, though it differed in intensity depending upon the time, quantity and type of caregiving task. The working caregivers had a repertoire of strategies to cope up with their problems, and they chose from them very selectively. Sometimes they accepted the situation to feel at ease, while sometimes they indulge themselves in the leisure activities to forget their work and stress related to for a little while. And sometimes
Dr. Deepti,
it is the next one is the last slide. found reliance in their family. Some of them actually, sometimes they found reliance in their family or the friends and chatted their worries away. So to conclude, I would like to say that the needs of elderly are many and complex, but the physical and mental health needs predominant given the fragile health condition of the elderly. The process of caregiving and the care seeking is generally very demanding. The study painted a very disturbing picture regarding the physical health and the overburdened care provider amid their own deteriorating physical and emotional health and well-being. The caregiver met the demands for care and support required by the elderly. Though the relationship among the family members was good, the physically exhausted and stressed caregiver unknowingly resorted to elders' abuse and neglect. Therefore, support from family and cooperation of the elderly is is in such a scenario would not only help in elevating the caregiver's work pressure, but also actually neglecting the caregivers, reducing the caregivers' work pressure, but also would relieve their sense of burden. Though the elderly were contented with the care and support they have received, they were confined indoors and could not attend social events, visit religious places, and travel without support, which was actually absent. And apart from that, a very good suggestion which elderly and the care providers have told that because they should receive financial assistance from the government in form of the pension or maybe the health care so that they can live their life happily. One important part which I missed to mention that we could not find any support from the husband, which was actually mentioned by the respondents. Thank you.
Thank you, Dr. Deepthi, for highlighting the various nuisances related to the caregiving and the perception, and also the bi-directional flow of care and support, which usually we ignore in our literature, and the coping mechanism through a qualitative study. And it is also a fact that today's caregivers are tomorrow's care receivers. They also realize that when they take any decisions. So friends, we had 6 very interesting papers dealing with the health, caregiving, living arrangements of the elderly. Now I invite Dr. A.G. Khan, the discussant, for his comments and remarks on the papers. Over to Dr. Khan. Please unmute Dr. Khan.
Now I am audible.
Yes, fine. Please go ahead.
Good afternoon to everyone. At the outset, from morning I didn't miss anything. From 11:30 onwards till now, I am totally following the business which is going on from the preliminary session till here, and I appreciate my good friend T.V. Sehgal, his dedication, particularly Professor Raju from TISS, and especially Abu Saleh Sharif. I know him. He is a good friend of my MPhil guide, Dr. Guru Swamiji. Both they did well their PhD in Australia from under John Caldwell. Okay, let me congratulate, as Dr. Sharif discussed in his comments, to start from there. LASI is whoever is sponsored here from Government of India and national international bodies, starting from Professor Arogya Swami to my good friend Professor T.V. Shekhar, the way they carried out and they brought it and made it available, such a huge and vast variety of data on aging. It is really an excellent, appreciable work at the outset. And coming straight away to the presenters, it is really hats up to all the 6 presents. It is 100% attendance. They are all presented very well. No single part have left the data which is available, I think, in IAPS on through LASI. I am going to say my views on 3 stages, not much taking time. looking at the presentation and the analysis of all 6 papers, which is a mix of qualitative and as well as quantitative research. It's a good and excellent studies, especially for policymakers. More than policymakers, I rather focus on the target group. Target group in the sense, as TV Shekhar says, that whoever is now the caregiver, they will be the care receiver. That's what I mean to say. The target group is the senior citizens. I think they have to understand from all these studies and try to restructure or rebuild their last days of life. That is more important. Rather, we are again, as a good old fashioned or customary thing, we are focusing and suggesting government should do that, government should do this. That is okay, but now the time is that we have to take care of voluntarily ourselves. We have to plan. Looking at all these things, basically all these papers focus on elderly people's, their health issue, their health care, their health utilization, their health expenditure, and their health treatment taking behavior, living arrangements, and single person household. And preference will be given, either they will go for public or private institution for their health seeking whenever they are in need. So the way technical session 5A is altogether, in my opinion, it is a good combo with a package of full of above mentioned points which they have covered as a objectives or aim or motto of their specific studies. I think that will serve the purpose. I believe it will fulfill the motto of families. Particularly, one has to mind to rethink the glorious primary function of family, what it was there, like giving the rearing and caring and protecting the family. I think slowly, which is disappearing from all of us. I think let us not forget that we have a historical concept in our culture and custom, that is Varna system. Focusing or thinking of others or expecting from children or relatives and kith and kin. Like look at the Varna system, the last stage when we are crossing 50 years or 75 years. So we have to get away from the moha. This what moha is a Sanskrit word. From all these materialistic things, I think we have to think of spiritually and get away from all these things. I think this is the best way one can spiritually involved and get away from materialistic things, so that will work as a sanjeevani to many elderly problems which they are facing and we may face in future. Even we have taken a study here in north part of Karnataka. That is one of the main reason what we have come across with all these presentations. Small practice norm and its impact on elderly care, as Ditya has taken working women and elderly care. Basically, in my opinion, we are practicing small family norm and it has a direct effect on our elderly care. Absolutely, there is no doubt. Particularly, these are the few things I wanted to tell here. But I have few observation also before that, like all the, it's not a clarification, rather observation. I was going through all the 6 papers. The first paper, I don't want to name, just first presentation. My observation is that it is one of the finding they were telling, but due to not availability of good specialized hospitals in northeast part of India, maybe the main reason for they are preferring public utilization in healthcare as well as healthcare system. This is my observation about that particular paper. Then the second paper is that they have mentioned in the finding that almost all single woman household is 7.4 in India. So more among, and they are found to be more among poor families. But rather it may be, why can't it not be in a rich family? That has to be looked into because of international migration of their children by and large. Even this findings may come in a rich family also. That can be looked into further. Then third paper, living alone. Males are 60% who are living alone, and female are 85%. Maybe it is vice versa, because women are more preferable than male as per their service providing nature is concerned. And it has come out very much from the last presented Dipti's study also that proves that my observation. Then the fourth one is whether it is with locomotive or without locomotive. If the older people staying with family, things will become very easy. That is what my thinking. Instead of, and he tried to compare the data, LACI data with Kerala and UP, which is very heterogeneous in so many ways. Rather, if he would have compared Kerala data with Kolkata, which is a culturally and in many things it is a society is homogeneous sort of nature. That's what my observation. Then the fifth one is basically thematical review. He has done it. It's excellent presentation. He has brought it so many things in detail, but he would have added one more point or exercise into that. That is this type of critical review when you take up, one has to find out the research gap exactly and try to develop a theoretical framework. That will be the contribution for the future researchers, how one has to go ahead. Then last presentation, Dipti's, of course, it is a qualitative research. Snowball sampling is absolutely correct. Maybe the situation, the pandemic thing, I think the way she has carried out, excellent, hats up to you, ma'am. But it would have been a representation from cross-cultural section. You would have added another essence to your study. That is what my observation. And before concluding, I have few words. Dr. Shekhar, with permission, 2 minutes only. That are concluding remarks, reminding today's reality, what exactly the reality is at a grassroots level in today's world in society. So let me tell you, we have lots of big houses, but we have very small families, you know, even though there is no space for Janani. Janani means who has given birth to us. We have constructed duplex bungalow, big flats, but we don't have a place to give our elders, our parents who have given birth to us. It is very unfortunate. Then mother, whether she is rich, healthy, poor, whatever it may be, mother can take care of 2 children in today's world. But those 2 children cannot even take care of one mother. What a fate. One has to think, we have to seriously about this. There are parents who are lucky and unlucky friends. Some unlucky old friends get respect. It is point to be noted. Some unlucky old parents get respect from their family only after death. How unfortunate it is. still they are alive, we won't think of them, we will neglect it. It is really painful. Then we have all the time to do all materialistic things in this world, but we do not have a 60-second in a day to spare or spend with our old or elderly people who have already spent a lot of time, their all time, day and night, for us, feeding us, caring us, securing us, and supporting us in order to grow up in a way. In return, what we are doing for them, we are just taking up them in a conference call and say, hi, hello, how are you, take care. We will be sending money for that. It is really painful. It looks so. Anyway, for heavenly sake, please, we have to think of seriously looking at all this data and analysis. It's a nice presentation from morning till today. Let us turn towards our elders. Those who have parents, please, I request them, turn towards your parents before they turn off from us. Ultimately, the question will remain whether the aging is a mistake or it a problem. No. Psychologically, if we prepared, well planned, it is a reversible with positive thinking. I think this is what I mean to say. Giving me this opportunity, thank you, my good friend Shekhar, Dr. Professor Nagraj, Saidunisa, and Professor James, and all the presenters, wherever you are, however you are, seeing it, the situation in Maharashtra, particularly Mumbai, I request all of you, keep distance, use mask, and wash your hands properly. Whoever is listening and attending as a participant, thank you. Jai Hind, Jai Maharashtra.
Thank you, Professor Khan, for your
one second, sir.
Yeah. Okay. Thank you, Professor Khan, for your valuable comments and observations. I think we are almost crossing the time limit. There is another session at 3:45. So I think, unfortunately, we don't have much time for discussion. And I hope the paper authors are taken care of the comments and observations. And I think we have to conclude it here because there is another session going to start at 3:45. So thank you all for your good presentations, interesting findings and observations, and participation. Thank you very much. From Manoj, you want to say anything? I think we will